Good evening, everyone. My name is Idren Itokopan, and today I'm going to be talking about diabetic nephropathy. Diabetic nephropathy essentially is a disease that affects millions of Americans today. Matter of fact, is one of the leading causes of renal failure today in the United States, and it can also be classified as a nephrotic syndrome. Essentially, the reason of doing this video is to talk about the pathophysiology of nephrotic syndrome. So before we begin talking about this pathophysiology of nephrotic syndrome, I'd like to go through, a few structures here, because this is going to be the core structures that we need to know in order for us to understand diabetic nephropathy. You have here, right, the afferent arterioles, where arterial blood arriving at the nephron is coming from, and it has to go through these glomeruli here. It has to go through the glomeruli here, and then comes out of here in the efferent arterioles. Right? So that's the pathway of blood supply. And the next structures that is going to be of importance to us in this discussion is going to be this group of cells here, right, called the intraglomerular mesangium, right? So this group of cells here, right, called intraglomerular mesangial cells, right, is another thing that is going to be important to us in this discussion. So what is the function of these intraglomerular mesangial cells? Well, pertaining to our discussion, they mainly make collagens, right, to help maintain the architecture of these glomeruli, right? Because as you can see here, the glomeruli are essentially, they have this curl kind of curve architecture. So in order for them to be maintained in that curl shape, you need the collagen to kind of fix them and hold them in place. So that's one of the functions of the intraglomerular mesangium. Obviously, they do other things other than just maintain the architecture by secreting collagen. But in terms of our discussion, they make collagen that help in maintain that architecture of the glomerulus. So what essentially happens here in diabetic nephropathy is that obviously you're going to see it in a patient that has diabetes, and not just diabetes, but uncontrolled diabetes, chronic uncontrolled diabetes. So the person has had this diabetes over a long period of time, and obviously because they're having hyperglycemia, blood sugar is essentially high and it's chronically, right? So you're going to see essentially what we call glycations. So you're going to have glycations. So you're going to have glycation, which is when the sugar essentially attached to proteins without the use of enzyme. So you have glycations, right, that is going to occur, right? Where are these glycations occurring, right? Obviously, they're going to attach to the basement membrane, glomerular basement membrane. They're going to attach to glomerular basement membrane. But another thing another place that they're going to be attaching to is going to be the efferent arterioles, right? And by essentially this sugar attaching themselves to glomerular basement membrane and efferent arterioles, it causes vasoconstriction, which essentially leads to increase in glomerular filtration rate, so GFR, right? So you're going to lead to increase in glomerular filtration rate. And what does this do when you have an increase in glomerular filtration rate? Because obviously it's chronically. So having this increase in glomerular filtration rate chronically lead to barotrauma, in which remember you had the glycations on the efferent arterioles and the glomerular basement membrane. So because of these excessive glycations, the basement membrane is also stiffening. There's increased pressure within the system, and you're going to have pretty much damage, barotrauma. So because they are damaged, right, proteins will start to leak out. Proteins will start to leak out into the Bowman space. So you're gonna see proteinuria, which is one of the reasons why this makes it a nephrotic syndrome. You're gonna have the proteinuria greater than 3.5 grams per day and all of the other stuff, right? So proteins are gonna be leaking out. But another thing that you're gonna have within this system is going to be inflammation, because you've just damaged the basement membrane, you've damaged a couple of cells, you're going to have inflammation. Inflammatory cells are going to roll in and they're going to release inflammatory cytokines. So essentially what occurs when you have these inflammatory cytokines release, they're obviously going to stimulate this group of cells that I mentioned earlier on, the intragranular mesangial cells. So when you have this stimulation of these intragranular mesangial cells, right, they begin to proliferate. So they're dividing and dividing. So you have more and more and more of these cells, right? You have more and more and more of these cells, right? And they end up in what we refer to as mesangial, intragranular mesangial expansion. Intragranular mesangial expansion. Or another name that you can hear it in some literature or in some texts is going to be called glomerular sclerosis, because those cells are dividing, right, but they're obviously also making their product, which is collagen, which causes the sclerosis, right? So you're gonna, now one thing you're going to hear is going to be intraglomerular sclerosis. Sclerosis, right? So if you go back and look at the picture that we had earlier on, right? Essentially within here, right, you have these cells here, intragranular mesangial cells, right? They're expanding and they're making tons and tons and tons of collagen that essentially is going to clog up this whole area. Because this whole area is then filled with collagen, nothing goes in and nothing goes out, right? So obviously it can no longer filter plasma within this particular nephron. So since you can filter plasma within this particular nephron, so you're not going to have any filtrate rolling downstream. And obviously this nephron is damaged. But like we know, in your kidneys, you have about 1 million nephrons in there. So that's just one out of the picture. So over time, you can obviously see more and more and more of these nephrons will be damaged. And because they're damaged, right, your glomerular filtration rate is going to decrease over time until you get to the range of end-stage renal disease, which is about 15 milliliters per minute. And at that stage, you're probably going to need a renal transplant or be put on dialysis if you're going to keep on living. But if you take a look at here on the histological slides, because what I just showed you is just on the cartoon. If you take a look here, you're going to notice this is what you're going to see on a histological slide, a light microscope histological slide that has been stained with eosine or so-called H&E stain, hemotoxylin and eosine. But the eosine is the pink stain, and obviously hemotoxylin is staining the cellular nucleus with the purple stain. So you can kind of see eosinophilic nodules here, right? You can kind of see this eosinophilic nodules, which actually gets in literature, you see those nodules being called commucins, commucins, commucin, Wilson lesions, right? So essentially, they are pretty much these lesions that you are looking at here. So once you look at that and you kind of see that, you're looking at a diabetic nephropathy, And you can see from these pictures that essentially the whole nephrons are essentially going to be, they're going to be clogged out. And because they're clogged out, that takes them out of business. And essentially that's pathophysiology of diabetic nephropathy. Hopefully I've been able to clarify some issues and help you understand the pathophysiology of the disease a little bit more better. Thank you.